All right, well, thanks for everyone joining this webinar hosted by the Subcortical Surgery Group. I'm honored to help host and moderate the session. The topic today is tissue management intraoperatively, really related to chordoma, which is a really, many ways, challenging disease to manage both surgically and adjuvantly. And you know, we're thrilled to have really amazing speakers, which I'll get to in a second. For those of you who may not be familiar with the Subcortical Surgery Group, it's really a user group aimed at reinventing, reimagining, and popularizing minimally invasive surgical approaches, you know, particularly the subcortical space, and you know, making sure that our surgeries are maximally impactful in terms of their therapeutic success and minimally impactful in terms of morbidity. For those of you that might be interested, this is how you can join the Subcortical Surgery Society, see what events are upcoming, how to, you know, participate in training courses and things like that. There's more webinars being planned, including one on the new IMVAX trial, which is basically a trial looking at using a particular oligonucleotide against IGFR1 in patients with glioblastoma. And one of the PIs of that trial, Dr. Andrews, will be the one hosting that. So particularly as it pertains to this talk, there are a number of challenges with intraoperative tissue collection. You know, most of my work is related to neuro-oncology, and in particular, malignant gliomas. And some of these same themes are something we deal with all the time. Number one, how do we annotate the tissue that we get from the OR? How do we take account of how we process the tissue, for example, cell culture, downstream sequencing, whether it's DNA or RNA, how are those things affected by the mechanism through which we extract the tissue from the CNS? And then do our, you know, tissue processing methodologies take into account spatial heterogeneity within the tumor cells? So particularly for polyclonal tumors like GBM and some other malignancies, getting good spatial representation and orientation, you know, could be potentially important as you design cell culture models or organoid models that attempt to recapitulate the primary tumor state. So, you know, with that in mind, we have two great presenters, both of international renown. We have Dr. Gardner from the University of Pittsburgh, who will be talking to us about his use of his approach to tissue preservation and collection as it pertains to endoscopic skull-based surgery and chordoma. And then Dr. Manmeet Ahluwalia, who's a close friend and collaborator from the University of Miami, from Miami Cancer Institute, who is going to talk about adjuvant therapies in this context for chordoma as well. So guys, thanks very much and look forward to your talks.
Thank you. I'll jump right in if that's okay. Can you see my screen okay?
Yes,
Yep.
looks great.
Okay, wonderful. So I'm going to be talking about tissue collection in general in skull-based surgery with a special focus on chordoma and basically the uses that I see with tissue collection. And of course, obviously this is focusing on things like the NICO Myriad, but how I use it and what I see as the clinical and research value for this tissue collection. These are my disclosures, which are not directly relevant for this talk, although I will discuss the first one in some degree when I talk about tissue collection. We were some of the main developers in endoscopic endonasal surgery. I'm fortunate to be part of a center that was really one of the originators of all skull-based surgery and then has a long lineage across all types of skull-based surgery. And with all of skull-based surgery, there are different phases of the surgery. There is the exposure or the approach, there's the resection phase, and then there's reconstruction. Of course, here I'll be talking largely about the resection phase, and the general concepts that we deal with in all of neurosurgery are there's a concept of internal debulking, we then do extracapsular dissection around the outside, and we use gentle countertraction with sharp and blunt dissection. In other words, we don't just pull the thing out, And we also want to look at critical nerves and blood vessels. So this sort of encompasses very generally all of the concepts around tissue, both resection and harvest. Now, in the skull base, as many areas of the brain, there are a lot of challenges. There are deep corridors, regardless of if you do a large open approach or a quote minimally invasive or keyhole or endonasal approach. There are often fibrous tumors. Sometimes we get blessed with soft ones, but they're often fibrous tumors. And then we're always dealing with critical neurovascular structures whenever we're working around the skull base. This particular device was developed with those concepts in mind. It is, it is unidirectional, so you can control the direction largely to ensure that neurovascular structures are not contacted. It can deal with very fibrous tumors, and it can reach down deep corridors. So it really fits and meets all of the challenges that we're dealing with. Here's an example of it used for meningioma, which is really where we largely used it. And you can see a very fibrous tumor here that I simply, even with the Myriad, I'm sort of struggling to do a debulking, but without it, I would essentially be pretty useless altogether. So here you can see it pretty successfully debulking this fibrous tumor. And we're in the center of it. And the problem is, if I don't have a method for debulking this, I either have to spend hours and hours slowly cutting it out, or I get impatient and I pull the thing out, at which point I create a problem. So here I'm dissecting through the tumor, finding the capsule in the depth, and making an edge for the Myriad to debulk. So I'm just trying to debulk up to the edge of the capsule, and that eventually will get me my debulking so I can work around it. You can see how this has been now up to a very thin edge of capsule. Here's another example showing really more than debulking, but really how it can be used on the edge of things right next to critical neurovascular structures. And this kind of somewhat goes through a little bit of my learning curve that took me into using it for malignancies like chordoma. So this is a typical patient with a large tubercular meningioma. You can see extending down into the cella itself and invading over the top of the carotid artery, which despite that, of course, we can access that by decompressing the optic canal. So this is showing first a cellular decompression. And now here's the key maneuver, just as we would do with an open approach. Here I'm decompressing the optic canal. You can see using an irrigating drill bit to ensure I don't overheat on the canal and cause nerve damage from the heat from the drill. And then working above the optic canal with an angled endoscope. Here's the optic canal itself. So by doing this very wide exposure and complete decompression of the optic canal, I can reach that tumor that goes over the top of the nerve, between the nerve and the artery even. Once I've decompressed that and remove the planum, now I can start to open. Here I'm opening up to the superior inner cavernous sinus. I'm not exposing too anteriorly because I don't want the tumor and the anterior cerebrals to fall down. So I just expose right up to the anterior margin. And I'm hoping here that I can use my usual technique, which is 2 suctions. If I have a nice soft tumor, 2 suctions, it just comes falling out. And these are the videos we all like to show at a conference, is the nice soft ones where it just comes out beautifully. But you can see this is exactly what I don't want to find when I first open into the tumor, and that's a very fibrous tumor. So I'm trying with scissors to try to debulk it. I can work around the edge of it. But when a tumor is just too large, you're either tempted, as I mentioned, to pull because you don't debulk, or you're just going to spend hours trying to nip away at this thing and maybe even damage it with your scissors. So here I take some specimen and then we start to debulk next with the Myriad. So it works very nicely and it's kind of a clinical utility. There I'm using scissors, and now this is, you can see how much more efficient this is than either the 2 suctions or the scissors for a tumor like this. Now obviously I have found my edge. So I've dissected my edge first before I debulk it, but I can go back and forth between that and the debulking. And here I'm dissecting free the optic canal and the optic nerve. And here you can see the nerve completely dissected free. We've gone over the top of the optic. That's a little avatine packing there. And then multi-layer reconstruction, including vascularized. Here's the immediate post-operative CT. We got an MRI later showing complete removal. Now, Petroclival meningiomas, working down to the clivus, is much more challenging area. The neurovascular structures can be wrapped up inside the tumor. And of course, any of the debulking devices can damage nerves or arteries if you don't control the directionality of them. Here you can see this patient has some hydrocephalus, and you can see the degree of compression. We'll have to do a pituitary transposition to get up to the top of this. And I won't belabor the exposure here because it's not really critical. And we did this in 2 phases. And here, once I've done all of the exposure, I stimulate to try to find the 6th nerve, because with the Petroclival meningioma, the relationship to the 6th nerve is just about impossible to be sure of. Actually, here I was fortunate to be able to stimulate it and localize it early on. I can get a little specimen. And initially this is soft, so I'm happy, but as I start working into it, I get into the fibrous central core of it. And so again, out of efficiency, I switch to the Myriad. So here we can see debulking the tumor. This doesn't have the same spray as some of the other aspirators, some of the ultrasonic, for example, which also work very well, but they have a lot more spray. So we finished our stage 1 with just a debulking. Again, large surgery, so we finished at 2 o'clock one day, and then we have another full day at the end of it the next day. And here you can see our final result, where we've completely decompressed. I've preserved the 6 nerves. You can do indocyanine green to visualize all the perforators and looking at our flap as well. And then again, do a multi-layer reconstruction. Now, this is a lot of our nurses like this because it's quick and easy. So I don't have to decide at the beginning of surgery if I have to use it or not. I can wait and decide later on. One thing I've just recently started using, and more so, is this preservation system. It preserves in a frozen fashion your tissue. And this became especially important when I started doing more and more chordoma research. One of the issues with chordoma also is seeding. So here you can see a patient who we did a transnasal approach on, and we did a nasal septal flap on the left side, which demucosalizes that area. And you can see that there's been seeding here, which we missed initially until it finally grew quite large in the anterior nasal cavity, essentially eroding through the upper hard palate. So obviously this had to be resected. So here you can see my partner, Dr. Wong, our ear, nose, and throat surgeon. You can see the tumor sitting on top and growing through the hard palate. So he did essentially an en-bloc resection, including the mucosa. Here you can see him working back and forth between the mouth and the nose, taking care to prevent this from seeding. Ends up with a little bit of tumor spillage, but gets a wide margin onto the septum. Now the issue is, when he gets a radical resection of this, there's going to be a hole in the hard palate. Here you can see the last bit being resected, and there's the hole left. So he did a little rotational flap here in the mucosa. You can see a little bony removal further, a little rotational mucosal flap to cover this defect. So this is not a minor thing to have a seed like this. It's something we want to try to prevent if we can. It's a relatively large surgery and took a very creative and skilled surgeon to get a good result. We looked at seeding in our recent series. Out of 173 surgeries, it occurred 1% of the time. Either end of the spectrum, one was a 10-year-old, the other one was 79 years old. And these occur somewhere around 1.5 to 2 years post-operatively. Obviously, we missed it a little bit in the older patient, but these both occurred in the inferior turbinate and the floor of the nasal cavity, and we both resected and then did radiation for, and neither has recurred. Now, interestingly, these were aggressive pathologies. So I'll talk about in a little bit the different ranges of chordoma, but these were both aggressive tumors, and they both occurred on the left or blind side where I'm taking my instruments in and out and potentially spreading it on the surface. Also interesting to me is that there is a difference if you compare open versus endonasal surgery. It seems to be a dramatically lower rate in endonasal surgery, and I'm not sure if that's that the mucosa is somewhat resistant to it as opposed to bare tissue, but it's really quite a bit lower in endonasal surgery, and I don't think that's a matter of recognition. Things that we do to protect it, we use these nasal sleeves. I do have the COI for that, and that I was a consultant for it, although it certainly hasn't provided anything to me yet at this point. And then I think the NICO Myriad, because I don't have to take it in and out of the nose, is a very another way to prevent the seeding. And I'll demonstrate that in this particular case. This is a craniocervical junction chordoma presenting with some trouble swallowing. You can see the tumor involving the craniocervical junction. And so we offered him resection. And this is our little inverted U-shaped rhinopharyngeal flap that we try to preserve to separate the oropharynx from the nasal pharynx. We tuck that down behind the soft palate and then start working on the tumor. So here we're debulking the tumor. And the advantage of this internal debulking is I don't lose any tissue if I'm using the APS. And here you can see when I'm trying to just peel the capsule up, this works very well. It tends to have a ligamentous encapsulation, so I can sort of deliver it up, and then I can release the ligamentous attachments of the tumor. It's important to try to not enter into it, but as I pull tumor in and out of the nose, you can see little bits of tumor getting stuck in this SPIWay, and if I don't have that in place, they get stuck on the nose and can potentially seed. So rather than pulling in and out, even though this tumor is relatively free at this point, I'll debulk it and capture it all in the APS. So this allows me both to capture tumor, which is very important for my research, but also to prevent this seeding, which is, I think, exceedingly important. And now we can resect the bony portion, make sure we get good wide dural margins. You can see it actually did not involve the dura, or the periosteum, just went up to the tectorial membrane. So I could peel it free, get a radical resection, drill out some of C1. And here's our post-op. So another role that it plays, not just preventing seeding, but this helps me very easily collect tissue. It can be very easy to suction up a chordoma. They can be soft tumors. So this ensures that if I suction it up or if I chew it up, I will be able to save the tissue. Using, saving tissue was very critical for us. We were tracking it, doing molecular markers on it. And my partner, Dr. Zanonos, looked at progression-free survival based on a whole lot of different molecular pieces, fish being one of the main ones, and we looked at a lot of different ones and found that 1p36 and 9p21 were really critical. If we looked at those alone, they actually turned out, in addition to a couple of other ratios, turned out to be statistically significant. We did a multivariate analysis. The 9p21 and 1p36 were the most significant, and they really split chordomas into different tumor behavior types. And this has been a dramatic difference. We all have seen chordomas that are out of control. We've all seen chordomas that basically don't require any other treatment other than removal. So for example, here we might have this 33-year-old. We think maybe there's a little bit of residual here. Well, what do I do? Well, this is a very highly deleted tumor. So that means I probably need to do something if it's highly deleted. Or if I have this kind of tumor where it's a little sort of middle grade, that may change my plan, maybe just radiate it. And if I have this very benign tumor that is lacking much in the way of mutations, then I can perhaps even just observe it. So when we split this into different prognostic categories using just 1p36 and 9p21 fish, looking at homozygous deletions, we can actually split this into 3 different prognostic categories. But of course, I need the tissue. I have to be able to collect the tissue for my pathologist to be able to run the fish analysis. If I'm able to do that, when we looked at our patients, this splits it very clearly into 3 dramatically different groups as far as progression-free survival goes. So we started applying this now for a couple of years and found it to be very useful. Here's an example. This is an 11-year-old girl who presented with diplopia, gross total resection of a chordoma. Here you can see the pathology. Not only did I get a gross total resection, but I got a radical resection with quote unquote negative margins, where when I cut around the edge, I didn't see any tumor in that. At the same time, this was a tumor that was not very deleted. So 0% homozygous deletions on P16 and no 1P36. So that helps me know that this is in that lowest and best prognosis. Now, this is critical because this is an 11-year-old girl where normally I would radiate, which means that's going to affect her puberty. It's going to make it more difficult for her to have pregnancies later, and a lifelong panhypopituitarism from radiation to the area does have significant impact on quality and quantity of life. Here's a 38-year-old man with a similar size tumor, slightly different location, also symptomatic, also gross total resection, also negative margins. But in his case, a much more aggressive tumor. Look at the amount of mutations he has, 84% homozygous in P16. So this is someone who sits very squarely on the mid or upper part of this intermediate prognostic area. And so I recommended proton beam for him. And we're studying this further to see where is radiation needed, where is it not. This creates very efficient workflow. They always want frozen tissue. And sometimes I'll forget, I'll take specimen and leave it on the back table and forget to freeze it. This takes it immediately into a frozen bath, and I have fresh frozen tumor that can go to my bank. And this can lead to this kind of analysis for pathology, or also even other studies like DNA and RNA. So doing this, we had also were collecting both tumor and blood for matched specimens over a period of time. And the question I wanted to know is, I'm used to grasping it with a rongeur and carefully taking out the tumor and, preserving the cells. Is this NICO chopping it up? Is this affecting the quality of my DNA? So I have to credit Dr. Andy Ventiker, who's at the University of Minnesota, did a fellowship with me, but has an absolutely spectacular background. I have to be honest, I've not always been the biggest believer in the true double threat, someone who can operate and manage clinically and also is a researcher, and that's probably partly because I struggle to do that. But Dr. Ventiker is truly able to do both. And this is some study that he did looking at the difference in the quality of DNA that he needs to do this type of genetic research that he's doing on our chordoma specimens, and look at the quality between NICO and the rongeur. It's exactly the same. I don't know, which one of these is the gold standard between them or which one's better, but they certainly both meet the quality with no peaks lower than 300, which shows that the DNA is preserved. The same thing goes true for RNA. Oftentimes RNA sequencing and other multi-omic type of techniques are far more useful than trying to do a whole genome sequencing. So the same thing holds true for RNA. You can see these nice robust peaks from the NICO, as well as when we carefully peel it out with a rongeur. This has led to, interestingly enough, looking at RNA sequencing, has led to 4 different subgroups of chordoma. And you can see how this sort of fits and does a further breakdown of our intermediate group, which sits a little closer. There's a very clear good and poor grade chordomas. And then interestingly enough, if we look at the RNA sequencing, we can also break down 2 different intermediate groups. So I think this really shows that there are dramatically different types of chordoma. And this all will change dramatically, at least how we have treated, and I think how others will treat if we can show that this is truly can be validated in other centers. And all this came about because of our ability to safely and easily save tissue, preserve tissue. So I've started using, I've used the NICO Myriad for a very long time for fibrous tumors. And then once I saw this seeding endonasally, I started using it for debulking the tumor, so I'm not pulling tumor in and out. But the truth is, this helps me collect tissue. And this can be very important. If I have a smaller chordoma, for example, I can simply debulk it. I can use just the suction mode on it, and I can save that tissue for the critical molecular analysis that I need. And then secondarily, I can then split it. And usually what we'll do, frankly, is we'll open the trap on the APS and we'll split half of it goes to pathology, half of it goes to research. And that helps me very much get similar specimens for comparison. These specimens have been used for animal models for chordoma as well. And I think that these kinds of, what you use to harvest your tissue and how you're able to use that tissue afterwards can be really, can be differentiators in the outcomes. So not only does it matter that I make sure that I have a device that works in the setting that I'm using it and also prevents injury as much as possible, but I think that this can be a critical piece in molecular and genetic research developments, which are going to drive the future of skull-based surgery as they've driven all of oncology. So this has become a part of my practice. I invite everyone with interest to join the Skull-Based Congress. This is a free educational website that we host that has all kinds of information, including sort of a skull-based community with blogs and case presentations, anatomy, etc. Again, thank you for inviting me part of this lecture, and we'll turn it back over.
Thanks, Paul. That was great. Manmeet, you're up, and look forward to your talk.
Are you able to see my screen okay?
Yep.
Looks great.
Okay, perfect. Thank you. Thank you so much for the kind introduction, Rohan. It's always a pleasure working with you and collaborating. And I just want to, before I start, just highlight and compliment Dr. Gardner, who's obviously extremely well known to this group, and someone I've interacted with more recently in great respect for the work he's been doing in this field. And I think I would like to also thank him for really setting the stage for my talk. And obviously, I'm a medical oncologist by training. I recently changed my jobs. I was actually at Cleveland Clinic for close to 15 years in total between my residency training there and then being on staff there. I came down south. I actually joined Miami Cancer Institute as the chief scientific officer, chief of solid tumor oncology, and the deputy director of the cancer center. But more importantly, I wanted to thank Dr. Gardner for setting up the thing, because in oncology, one of the mantras that we were all trained in is that tissue is the issue. And hence, I have always had a long track of a close working relationship with my neurosurgeons at Cleveland Clinic, but across the country. And I have great respect for them, because when they are operating, and those of you who are skull-based surgeons, I have the greatest respect. I mean, you guys operate like crazy number of hours, and technically just to see the skill set is just amazing. But more importantly, as Dr. Gardner alluded to, the tissue has become even more a focus in this era of precision medicine, because we are in 2021, when anyone who has any kind of healthcare challenge wants precision-based treatment. With that, I've been asked today to talk about genomics and chordoma, but primarily from the implications from medical therapeutics. So I'll discuss with you some of the data that exist out there in terms of some of the molecular targeted agents that have been used, but also make a pitch that I think we hope will be impetus for a close working relationship, and we can do some cool work together. So with that, this is my disclosure slide. So I am going to reference this very nice article which I came upon, which is a very nice systemic review of the molecular targeted therapy in treatment of chordoma. And as you know, some of the pathways which are altered in chordoma include the PDGFR pathway, the KIT, the EGFR pathway, HER2 pathway, VEGF pathway, PI3 kinase, AKT, mTOR pathway. And there are a number of targeted agents which are actually approved in other cancers. So the use of these agents in chordoma is all off-label and has been relegated to smallish trials or case reports or retrospective case series. And I'm going to discuss some of that data there. But obviously, but the biggest point today is hope that we can find ways to work together. Most of my work, frankly, has been in the field of glioblastoma and brain mets. But as I have interacted with chordoma, I think chordoma presents a unique opportunity for us to make a difference in these patients based on some of the work that Dr. Gardner has shown that he and his group are doing. So some of the agents that I'm going to discuss today are Imatinib, Dasatinib, which target the PDGFR, KIT pathway, Erlotinib, Lapatinib, which target the EGFR pathway, Sorafenib, Sunitinib, which target the VEGF pathway, and there are some mTOR inhibitors as well. So the way this study came along, they looked at, this is the Prisma flow diagram, basically on how they picked their studies. And this is, again, like I said, a fairly elaborate summary, and I have it referenced. So you guys feel free to read this. And if anyone wants, I'm happy to, guide you through the paper as well, if need be. But essentially, they looked at 133 publications, and then they used the various connotations. And basically, in the end, 33 studies were included in the review, and I'll highlight the ones which have most data on it. So in short, just to walk you over of the included study, the proportions of studies reported each molecular inhibitor. The biggest data is actually with Imatinib, if you look at just sheer number of publications, and then followed by Erlotinib and cetuximab. When you look at the actual number of proportions of patients who received every molecular targeted inhibitor, you can clearly see more than half of the patients have actually been treated with Imatinib, followed by Erlotinib. One of the challenges that we have in chordoma is obviously rare disease. It's like obviously a surgeon's disease, and then if they grow, and Dr. Gardner showcased some of the exemplary work he and his group has been doing to establish the prognostic factors on how to pick therapy, who to observe, who to radiate. And I always, as a medical oncologist, obviously, I see patients with glioblastoma frontline and now brain metastases frontline, because therapies are making effect there. But in chordomas or meningiomas, we are pretty much the last line, actually. So essentially, when they see me, they've exhausted other modalities. So with that, one of the challenges in looking at the response criteria is because it's all over the place. So one of the common criteria that is used is the CHAW criteria, where there is changes in the tumor size, but they also look at a density. And a radiological PR is defined as something that's 10% less in terms of decrease in tumor size or a decrease in the tumor density. The RECIST, on the other hand, defines this as a decrease in PR when the decrease in the tumor size actually is like 20%. So it's a deeper response compared to a CHAW criteria. So just that to keep in mind whenever you read a paper with a molecular targeted agent in terms of which criteria is being used, because so that you can compare apples to apples. So with that, I'm going to launch in with the most common inhibitor that actually has been used, and essentially that is Imatinib. Imatinib actually targets the PDGFR pathway, but it also targets the KIT pathway, and that's important. Imatinib actually, as you guys can recall, was the first targeted agent actually that was approved in oncology period, made the Time magazine cover in 2001, and was said to be the magic bullet, which would solve problems in oncology or serve as a basically as a role model on which other drugs would be targeted. It was a drug that was obviously used in chronic myelogenous leukemia. However, in that tumor type, more than 95% of the patients have that particular translocation that is actually oncogenic driver of the cancer. And hence, Imatinib really transformed this disease. A number of agents have come down the pipeline after Imatinib, which has converted CML from a 2.5-year outcome to 15 years plus disease. So what has it done in chordoma? It was extensively used. There have been 18 studies with Imatinib and over 220 patients treated, so very large. One of the largest trials till date was this one run by Dr. Stucardi, which was 56 patients. And essentially, you see there was a progression-free survival of 9 months, and you had an overall survival, which is pretty much the largest trials till date. So you have progression-free survival around 9 months, and then overall survival in 3 years ballpark. And then there was another retrospective study of 46 patients, which had very comparable progression-free survivals and overall survival. So with this agent that you use, you may have progression-free survivals of 10 months, and you may have overall survivals in the ballpark of 2.5 to 3 years. The challenge is when you're looking at it as that Dr. Gardner showed, that none of these patients had really DNA profiling or RNA transcriptome stuff. So when you are comparing these case reports or these trials, you don't know how much proportion of patients existed in each group. So when you don't have some of those prognostic factors, you can have outcomes which could be changed basis of this. Then there's more data in 73 patients who actually had a PDGFR expressing chordoma. We actually had some PR rates and stable disease, and a quarter of these patients actually progressed. But the PR rate of 45% was interesting. But that's, again, brings one to the point that if you have more targeted directed therapy, you may have better outcomes compared to if you take all comers. And that's the whole premise of precision medicine. And again, that's why I would make a pitch for tissue being the issue and good harvestation of tissue being a more important issue. Moving on to another inhibitor was Dasatinib. This was, again, now inhibits the PDGFR pathway, but also inhibits the SARC pathway, which is, again, upregulated in patients with CML. And we looked at this drug even in GBM because there's some SARC inhibition there. And essentially, there was a study done with Dasatinib even in GBM, which was negative. But here, when they looked at it in chordomas, they found in a phase 2 trial of 32 patients, a median progression-free survival in the ballpark of 6 months. So a little bit less than Imatinib. Again, can't cross compare. 2-year survival rates were around 43%. So median survival, a little less than 2 years compared to, again, Imatinib. And hence, Imatinib's been used more than Dasatinib when people have looked at off-label usage. Moving on to VEGF pathway, which is dysregulated in number of patients with chordomas, and hence Sorafenib is one of the drugs that's actually been approved in hepatocellular carcinoma as a multikinase tyrosine inhibitor, which targets the VEGF pathway as well as the PDGFR pathway, and hence the interest in this. There were 4 studies, and I would highlight a phase 2 trial again, where they used it in 27 patients. They saw a response in 1. Now they used the RECIST criteria. The 12-month progression-free survival was around 73%. Overall survival rates were around 86%. But here you're seeing that across trials, you have different endpoints, you have different criteria, so it sometimes becomes difficult to cross-compare them. There was another series where 11 patients were treated with Sorafenib, where they had PR in 1, stable disease in 9, and a progression in the patient. And then there was another trial where progression-free survival was around 12 months. So very comparable to what was seen in the Imatinib data. Moving on to a different VEGF inhibitor, this is Sunitinib. It's a drug that was actually initially FDA approved in kidney cancer, and it's a tyrosine kinase inhibitor, again, targeting the VEGF pathway and the PDGFR pathway. There are 3 studies which have been done in this. The largest phase 2 trial was around 9 patients. Again, you can look at it, it's relatively smallish studies. They had 4 stable disease by RECIST criteria. They had median progression-free survival of 12 months in patients who actually had stable disease. There was another case report where 2 patients were treated with Sunitinib and at least had stable disease. When they looked at the RECIST criteria, they had a PR that was maintained after 27 months of stable disease. Moving on to EGFR, again, there are a number of EGFR inhibitors. Most of the data that we have with EGFR inhibitors in chordoma actually include Erlotinib, which, as you know, was the first generation tyrosine kinase inhibitor used against the EGFR pathway, and actually was a drug that was approved in lung cancer. And a number of people have used it in lung cancer brain metastases, and it would have good responses. And now actually has been moved to second line because of a drug called Osimertinib, which has become state-of-the-art drug in that patient population. But here, Erlotinib was, pretty much the second most common agent. Has been analyzed in 10 studies, 16 patients, 1 clinical trial. There have been retrospective cases and 8 case reports. Monotherapy has been used, although sometimes it has been used in combination. There were 2 PRs and 5 stable disease in 5 patients where it was used as monotherapy out of the 7 patients who received this. This is again the RECIST criteria. And there have been case reports of patients achieving PR and significant tumor reduction seen in a couple of patients. And we've actually tried it in clinical practice with mixed results ourselves. Moving on to another agent that targets the EGFR pathway more through the HER2 pathway, and it's a drug called Lapatinib, which is actually FDA approved for breast cancer and has been shown to have some efficacy in breast cancer brain metastases. And there was a phase 2 trial. This was a little bit more driven by EGFR positive chordomas. Most of the times we have used IHCs in this in the previous world when studies have been designed, and 6 patients achieved PR and 7 sustained stable disease with a median progression-free survival of 6 months according to the Choi criteria now. So as you can see, you are having different response rates based on Choi criteria compared to RECIST criteria. As I explained it before, Choi criteria, it's a little bit easier to get a PR compared to a RECIST criteria. Sometimes you are comparing apples and oranges. Then obviously, as you in a field that has interest in this, there is a fair amount of excitement looking at immunotherapies. And this was a case report in immuno-oncology a couple of years back where they actually showed 3 cases of chordomas responding to immunotherapy. One of them was based on a tumor-based vaccine against Brachyury, and then 2 of them had anti-PD antibodies, and there have been other case reports as well with some of the PD-1 agents, which have shown to have clinical and radiological responses. And here you can actually see a patient who had chordoma, had a relapse here on the endoscopy, and here in June actually was being treated with immunotherapy. And then you can see in October, you actually see the lesion disappearing. And here's the MRI of this patient showing some regression, continued regression. And the patient, I believe in this case, had more than 12 months worth of clinical benefit with this agent. So what are some of the ongoing clinical trials with the different agents? Obviously, I looked at, discussed a bunch of data. There is a clinical trial with pemetrexed, which is a chemotherapy drug, looking at 15 patients. This is being led out of the Pacific Northwest group. There is a fair amount of CDK pathway alteration in chordomas, actually. And palbociclib is a drug that is a CDK4/6 inhibitor, and there's a fairly large trial going on in Europe with 43 patients. Afatinib is another drug that targets the EGFR pathway, and afatinib is a drug that's actually approved in lung cancer. And other than osimertinib, is probably a drug which is used extensively. It has some blood-brain barrier penetration, and hence the interest, at least in brain medicine. There's a 40-patient study going on. I have the NCT clinicaltrials.gov numbers here. And then there's a trial going on with nivolumab with 33 patients, effort led by the Hopkins group, Chetan Bedagowda and his colleagues. There is another trial that I did not include here, but it's a combination of a anti-PD-1 antibody Nivo and an anti-LAG3 agent, which is being sponsored by BMS as well. I think that's a relatively smallish trial of 15 to 20 patients. Just wanted to highlight a little work. Obviously, Dr. Gardner talked about some of the phenomenal work he and his group are doing. There were a couple of Nature Communications papers which just came out in the last year or so. Both Nature Communications looking at driver landscape in sporadic chordoma, and then there's another one at the skull-based chordoma. And this is the first one, which is the sporadic chordoma effort. This was actually, they looked at 104 cases of sporadic chordoma, divided them into a discovery set of 37 patients, and then they had a validation cohort of 67. What they found out was that somatic duplications of notochordal transcription factor brachyury was seen in around a quarter of these patients. These replicate or recapitulate the rearrangement architecture of some germ-like duplications of brachyury that underlie familiar chordoma and has been seen. And there have been efforts looking at vaccines targeting brachyury in this disease space. But they've also identified what we know is PI3 signaling mutations seen in around 16% of the cases. And there are a number of mTOR inhibitors. There is a PI3 kinase inhibitor, which are FDA approved. There are joint inhibitors which are going through clinical trials. What this paper was interesting was they actually found an innovating mutation in LIST, which was a novel mutation that was actually identified by these group and made it to Nature. And here is the discovery, 37 patient discovery cohort. Most of this was actually whole exome sequencing in 26 patients, and there was a whole genome sequencing seen in around 11 or so of the patients. And essentially here you can see, let me just walk you through this. There is a CDK N2A alteration, which is seen in a handful of these chordomas, LIST, which was seen in around 10%, as I said. And then you can see some PI3 kinase pathway alterations, which could include the PIK3CA or the PTEN and the PI3RA1. And then there's chromatin remodeling defect, which is seen in a number of chordomas. And then there are some other mutations, TERT, which we also see in glioblastoma, and then there's SMAD4 seen. So essentially highlighting some of the altered pathways when we are looking at the genomic sequencing. This is actually another paper now which looked at whole genome sequencing of skull-based chordomas, which identified genomic alterations. They looked at recurrence and chordoma-specific survival. Some of the work that Dr. Gardner was also sharing with this group. Again, a very busy slide, but what this group showed was they looked at 80 skull-based chordomas and identified PRBM1, which is basically a switch sucrose non-fermentable complex subunit gene, which was significantly mutated and was identified as a driver. This genomic alterations was seen in around 12.5% of these patients. And then they also had the homozygous deletions of the CDKA2NA 2B locus, which was second most prevalent event. This is actually leading to trials. We are talking to a company as well, which actually has a CDK246 inhibitor, which is we are looking at doing a study with them. So some of the summary or takeaway points is there is selection of these multityrosine kinase inhibitors for patients who have advanced or relapsed chordoma, which should be, I think, would be make sense with looking at DNA and RNA transcriptome data. Previously, we used to look at ISC and see if you can identify a driver. Not all the times, if something is present, is it a driver. Most of our work has been relegated to monotherapy of TKIs, which is still recommended as the first-line management. Combinatorial efforts may be used for drug-resistant chordoma. I think the key point here that I would like to make today is that clinical trial enrollment is preferred. This is a disease which is obviously rare, and we need more data. And then clearly, like everything in brain tumor space, I think multidisciplinary management is the key. So I again was thrilled to see some of the work that Dr. Gardner and his group are doing, and would love to work with him and closely, and a number of you on this platform as we try to define some of these agents and obviously define trials where we are collecting tissue to learn from our efforts, because a lot of times we do trials and we and several of us have been guilty of that in the brain tumor space, and because we cannot get enough tissue, we are not able to learn from it. And I'll just use an example in making a pitch for this. I was involved with a glioblastoma trial with a drug that was a base excision repair inhibitor, came out of Stan Gerson's lab, which was a Case Comprehensive Cancer Center director. And the trial, like all the trials in recurrent glioblastoma, was negative. However, what we did was we actually collected tissue at Cleveland Clinic, and we had treated around 14 patients, and 2 of the patients I treated on had a very nice long-term outcomes. One of them was progression-free for 18 months, another one was 30+ months. We sent the tissue over for RNA transcriptome, and we actually identified a gene signature that was actually present in those patients. We then went back to look at the TCGA, and that gene signature is actually present in 11% of glioblastoma. We also saw the bulk of our benefit in base excision repair inhibitor occurring in MGMT, and we are working on a cooperative group trial now, which is a follow-up to that trial, which will only include patients with MGMT altered pathway or MGMT mutated promoter methylation in glioblastoma, and will validate that gene signature prospectively. So I would really love for some similar kind of effort to come out of our chordoma interactions, because again, these patients are not as common, and I think here it's even more important that we work in a group, in a collaborative process, so that we can make a difference in lives of these patients. So with that, I would like to thank the SGUSG group for the kind invitation to talk today, and also for Dr. Rohan Ramakrishna for his kind introduction, and Dr. Gardner for an excellent talk. I would be open to take any questions. Thank you so much.
Great talk, Manmeet. So there's a few questions here. I'll just answer one really quickly. How does the tissue collection system work? It's basically a, cannula with a side cutting device at the end, and it, using higher or lower levels of suction, pulls in the tissue and then cuts it and dissociates it. This is in contrast to ultrasonic aspirators, which, as everyone on this call hopefully knows, is, will ultrasonically pulverize the tissue and then suck it up. With the with the Myriad, for example, you get to preserve some of the micro and even macro architecture of the tissue you're resecting. And then with the preservation device, it basically will bathe the tissue in, you know, whatever bath you want to put it in. So for us in gliomas, we'll bathe it in serum-free media, you know, to optimize for glioma stem cells. For other tissue types, you know, you can bathe it whatever you want. It can just be ice cold saline, as an example, to prevent the tissue from necrosing. So
yeah, as a filter too that captures the tissue, which is, I think, another important piece. That not much will get through it. I mean, a very thin cyst would get through it, but most reasonable tissue will not escape it.
Right, and it minimizes the amount of blood in the specimen, which is also a nice feature. There's a, Paul, I don't know if you saw this question. You know, you saw that we recently awarded a grant by the Chordoma Foundation. What are the next steps in your research? And will you focus on using the molecular information for therapeutic development for patients with chordoma?
Yeah, I think there are two aspects of it. I mean, one is to sort of take a step back. If you look at all of the studies that Manmeet showed, every single one of them requires some molecular understanding of the tumor. So we need to do beyond just typical pathological analysis to be able to enter patients in these studies, which is an important, again, tissue collection issue. There are a couple of things. One is frankly, you know, understanding, it both helps us guide clinically to look at these different categories. So if a patient is in the earliest category, the lowest grade, for example, then I think we could potentially avoid radiation in those patients. So it changes clinical guidance. But as far as trials go, I think it's very important to select the right patients. The truth is the patients that are most in need of chemotherapy are the grade, you know, either grade 3 on molecular or the grade 4 based on RNA sequencing. It's those patients, and those are the patients we should be focusing both our understanding of what their mutational burden is and what the potential targets are. And also when we do studies, we should be understanding which patients are being enrolled. To enroll a low-grade patient who has a non-growing tumor into a neoadjuvant chemotherapy trial for a VEGF inhibitor that has been picked up in these high-grade tumors will be ineffective. It's one of the lessons we've learned from glioma is you really have to understand the tumors on a molecular basis. I think that's one of the very important roles of it, is to be able to do that kind of a typing beforehand to take the right patients into it and also study the right patients to understand which of these targets to use. So there's a very clear group that would benefit probably from either neoadjuvant or immediately after surgical resection treatment with some of these other options for it. And I think that's the group that we need to focus on, and that's the group we need to understand better on a molecular and genetic basis.
Great. So the next question was for Dr. Ahluwalia. What are the key developments in the next 1 to 3 years that you think will change the development of targeted therapies for either chordoma or GBM? And as a follow-up, what are the areas that need the most funding to develop or areas to focus on?
I think, you know, I love the way Dr. Gardner and his group has approached, you know, some of the work that they've done, right, which is a very coordinated effort for years. I'll be honest with you, you know, chordomas, you know, I was at the clinic and I would always have Pablo Recinos and Varun Kashatri, great colleagues, you know, talk about it. And, you know, we would talk about doing something. So what I would say is we need a coordinated effort. And I would love to, you know, work with the group here. And maybe we, you know, work together. And I know Chordoma Foundation has been helping in the past. So I think, you know, there's definitely interest in the anti-PD-1 pathway, you know, which may be of interest. You know, we are seeing some responses there. Here, obviously, you know, at Miami Cancer Institute, we are a proton site. So we do see a fair amount of, you know, chordomas that will come here for the proton. And then as a result are in the system. But from a molecular targeted therapy, I mean, I would love to, you know, if possible, if I had a wish list, at least for chordoma, I'll speak about GBM, would be to create kind of a couple of basket trials, like, you know, having 2 or 3 groups of patients, have a couple of molecular driven therapies there. And if we don't identify any oncogenic driver than putting them in the anti-PD-1 basket and see what happens, right? So we actually have a call out to a company that on discussing this on Thursday, which has a CDK2/4/6 pathway inhibitor. So at least the tumors that are driven by the CDKN2A pathway, those would be the ones where I would like to treat them with that drug. We clearly know that in low-grade space, patients who harbor those alterations behave more like a GBM, right? They do worse compared to the other low grades. So I think clearly we have seen that to see it a marker. But it would be, I think it will need a collaborative process, more like a platform study of multiple institutions, because as I showed you, right, a lot of data was 15 patients, 9 patients, 8 patients, 6 patients, different entry criteria, and then you have different response criteria, and then you have data that you can't take anywhere. So some of the interactions that I'm having with pharmaceutical companies is, guys, we need a coordinated effort and try to get a couple of inhibitors in trials where they can at least look at potentially even FDA approvals, especially if you're going to see responses, right? Because FDA is open to approving drugs now based on responses, and we at least have some. So clearly the areas of interest to me would be the CDK4/6 pathway inhibitors. We're starting there, obviously continuing to look at immunotherapy, but look at maybe even combinatorial approach. There is a NICO trial. We wouldn't want to replicate that, but maybe look at a combinatorial effort with the checkpoint blockade with both anti-PD-1 or maybe IPI, if BMS likes the concept, although they have the NICO trial already. And that would be, and then collect actively tissue on it, and then learn from patients who respond versus patients who don't respond, so that we can have a better trials. And we are doing the same thing in GBM. We are working on something where we may have a molecular targeted umbrella trial of 6 to 7 agents, but it will be a large effort which will need more than 5-6 centers. So we are actually in early stages of running those concepts by companies, which will give us drugs. And I would in another minute say I'm also trying to do something through SWOG, which is a cooperative group where we just formulated a new brain tumor committee that I've been involved with. And I'm trying to formulate some clinical trials partnerships. If there are companies that will come there and they may have a chordoma drug, I might come back to your platform and see if there would be an interest in people in collaborating through that mechanism too.
It's interesting, the CDK4A inhibitor, also in our RNA-seq subgroupings, I think is a very promising pathway. So I think, what we do is, you look at these multiple studies and everything seems to be pointing at something and it fits that group that needs it. Those are the ones that make sense. So that's an obvious one. The PD-1, I think, would be very interesting, although it may be more in the chondrosarcoma group or certain subtypes of chordoma and not perhaps as broadly reaching. But again, it's, we're trying to understand where to apply these. And I think that these, multi-institutional efforts and where for a rare tumor like chordoma, it ends up, there's just no way to have all those competencies in one place in general. And so that's why, sessions like this and sessions that the Chordoma Foundation puts on are really important to bring these together.
Maybe question for you. So, one of the challenges with chordoma, unlike other malignancies, is, the progression, is really measured often in the span of 6, 8, 12 months, more like 12 months often, right? And so how do you design trials rationally where, if you're on, let's say, Nivo or Pembro or whatever, and you're on Q3 week dosing, you accumulate a year worth of toxicity, for the, in terms of comparing that to when people progress on average. So are there better ways other than progression to look at response potentially, as opposed to keeping people on some of these agents for a year plus?
No, so I think, there are two aspects to it. One is I think the home run, frankly, will be if we really start seeing responses, because that's the only way FDA will approve. Because if you look at all the studies, right, all studies were pretty much single arm studies, smallish or a little bit large, right? Whether single digits, double digits, or low double digits. FDA will never approve any drug on the basis of that. So all the efforts will probably go wayside. Sorry to say that, but learned in my few years in brain tumor space, right? We hardly have drugs approved and it doesn't help us. So I think a coordinated effort will be best. now, and that's where some of the work that Dr. Gardner and his group are doing, which helps us prognosticate, might be better indicator, right? So if you look at the patient and say, oh, you know what, I think you may not be doing that well, would be the right patient to go for longish trials. But I would really want to focus on a big interest of mine right now is looking at the CDK pathway, because we have a company that is really dedicated in doing something. And Paul, I might actually circle back to you if you don't mind. Maybe get a brainstorming session with you, and would love to get people on if they have, because I really want to make it a collaborative effort, because unless we all collaborate together in a large way, we'll all be doing our smallish efforts. And then 5 years later, Dr. Gardner might be giving a much more eloquent talk with more data, but I'll give up the same crappy talk with low inhibitors that are FDA approved or really readily available. And I think we need to learn from our previous experiences. And that's what I'm doing right now, both in GBM space, is just trying to push collaborative experiences rather than doing smallish trials. Because I'm guilty of that. I did that at Cleveland Clinic. We used to do small trials. We have some data. Now I'm talking with the company, and no one wants to put in like big money, because they all want home runs when you start talking about multi-million-dollar trials. So I think we have to be very, very deliberate. And I think the response, if you can get responses with the drug, that'll probably get people more excited, which is always tough with the immune checkpoint blockade. You can get more stability rather than responses.
Great. All right, well, we're at the end of the hour. So thanks, Dr. Gardner, Dr. Ahluwalia. Thanks to the SSG. I hope everyone who participated found this useful. I certainly did. And we'll wait for the next webinar. So thanks everyone again. And unless there's anything else, I think we'll end it.
Thanks a lot. Thank you.
Thank you so much. Bye-bye.